Hello everyone. Welcome to another VMR session. We are excited to host another teaching point recap. My name is Parisa. I'm going to facilitate today's session. Three amazing Academy members, Sosan, Rahul, and Patricia, are going to teach us about last month's VMR. And we are going to start with the first presenter. In meanwhile, if anyone has any question, please feel free to put it in the chat and we are going to address them at the end of each presentation. Our first presenter is Susan. Please feel free to introduce yourself and share your screen.
Hi everyone. Good morning, good evening. Happy Tuesday. I'm so happy to present a teaching recap today. So, can you all see my screen? Okay. So, I'm going to be talking about B12 deficiency, and I chose a case that was presented by Francisco on an IMG VMR with Cleveland Clinic. Okay, so we started with a middle-aged woman with a history of chronic opioid use dependence who presented with generalized weakness and altered mental status of unknown duration. Her laboratory findings showed severe macrocytic anemia, signs of hemolysis, and a picture concerning for a thrombotic microangiopathy. And after doing further workup, she was finally diagnosed with a condition called pseudo TMA or pseudothrombotic microangiopathy that was induced by B12 deficiency in the setting of pernicious anemia. And the clues for the case that this was not an acute thrombotic microangiopathy. Number one is the time course. Her hemoglobin was 2.2, which gives us a hint of that this was more likely to be a chronic process. And this argues against an acute TMA, the low reticulocyte count, the markedly elevated LDH. She didn't have any schistocytes even on repeating the peripheral blood smear. Her bone marrow biopsy showed teardrop cells, which indicate that the marrow is being crowded. We're having a process of ineffective erythropoiesis. So what is a thrombotic microangiopathy? We're having small clots that are forming in the microvasculature that can lead to shear forces to cause erythrocyte fragmentation, which can lead to something called MAHA or microangiopathic hemolytic anemia. And these tiny clots that are forming can lead to tissue damage. That's why, in our patient's case, given her lab findings, and she came with altered mental status, she had mildly elevated creatinine, we were highly concerned of a TMA process. And in order to diagnose an acute TMA, usually the key diagnostic findings are the presence of schistocytes, elevated LDH, thrombocytopenia, and ischemic tissue damage. However, talking about pseudo TMA, so usually we hear that B12 deficiency can present with a hemolysis or hemolytic anemia. And why is that? Number one, it's the pathophysiology includes having intramedullary hemolysis, and another theory concerning the presence of hyperhomocystinemia. So for the intramedullary hemolysis, now in cases of ineffective erythropoiesis and B12 deficiency, the RBC's membrane is fragile. So the hemolysis usually happens in the bone marrow before it reaches the peripheral circulation. And the other thing about the homocysteine levels, when we have elevated homocysteine levels, this downregulates the glutathione peroxidase. And this will lead to the accumulation of ROS, or what are known as the reactive oxygen species. And these further damage the endothelium and lyse the fragile RBC membranes. And so for the term pseudo-TMA, when you see a hemolytic anemia that is associated with number one, thrombocytopenia, sometimes schistocytes, and a B12 deficiency, this triad is termed as pseudothrombotic microangiopathy. And this is a rare presentation of B12 deficiency. It's not commonly seen. Um, and so the clues to that this is a pseudo TMA rather than a TMA picture, is the markedly elevated LDH levels, having mild bilirubin elevation, high MCV, and low reticulocyte count. And now talking about the LDH elevation, why the markedly elevated LDH can be a clue that this is a pseudo TMA, is that because the markedly elevated LDH usually occurs in a nucleated RBC, the immature, the smaller RBCs that still have a nucleus, they have a higher concentration of LDH compared to the mature RBCs that are enucleated. And the other thing is that the erythroid progenitors, they have a smaller amount of hemoglobin. That's why the bilirubin is not highly elevated in such conditions. And for the macrocytosis with the low reticulocyte cytosis is because the process of ineffective erythropoiesis. Okay, so now why is B12 important for us? Number one, because we need it for DNA and RNA synthesis, for heme and RBC formation. We need it for energy production, for cell division and maturation. We need it for the nervous system, whether for its protection and function, and for the homocysteine metabolism as well. And as we know, B12 is a cofactor in multiple enzymatic processes in our body. For example, it's a cofactor for homocysteine methyltransferase and for methylmalonyl CoA mutase. And that's why when we have a B12 deficiency and these enzymes stop working, we're going to have elevated levels of homocysteine and methylmalonic acid, which are used in diagnosing B12 deficiency, where we see the methylmalonic acid levels and homocysteine levels. Okay, so now I have two questions for you all. The first one is, which one of the following statements is true regarding vitamin B12 and folate deficiencies? Sorry for the choices being too long. Yes, it's just one statement. Um, okay, yes, it is number five. That's correct. And because number one, the incidence of B12 deficiency is higher than folate deficiency. For the B12 deficiency that can cause neurologic signs and symptoms, it's not only B12, because like even in folate deficiency in the early embryology, we can have, for example, the spina bifida and all these neurological problems that can happen from a folate deficiency. The anemia and neurological symptoms happen independently, and they're not related like with each other or like one precedes the other. Vegans are at higher risk of having B12 deficiency and not folate deficiency. And the correct answer is that the anti-glycemic medication metformin is associated with decreased B12 absorption. And this is now the second question. Which of the following test results would rule out a deficiency of vitamin B12 when the serum plasma level is slightly below the lower limit of the laboratory's reference range? Yes, the correct answer is 4. Yes, guys got it. All correct. Excellent. Okay, so what are the causes of B12 deficiency? We can have medications, as we talked about metformin in the previous question. Long-term therapy with PPIs, H2 blockers can decrease the absorption of B12 deficiency. Having any malabsorption condition, patients with bariatric surgery, for example, genetic conditions that can affect the enzymes that are responsible for the metabolism of B12, the diet, and autoimmune diseases like pernicious anemia. And the clinical manifestations are neuropsychiatric manifestations, cutaneous manifestations, GI, and hematological manifestations. So, in order to diagnose B12 deficiencies, we usually suspect it in patients with either unexplained anemia, unexplained hemolysis, pancytopenia, macrocytosis, the presence of hypersegmented neutrophils. However, we want to keep in mind regarding the MCV is that a normal MCV does not exclude a B12 deficiency or folate deficiency. And I've learned from one of the academy's member, Rahul, our friend, that is going to be presenting soon, that we can have multiple processes happening together at the same time. So having a normal MCV does not exclude a B12 deficiency. The other thing is that an MCV value that is like high a lot, like a value of more than 115 is more specific towards a B12 deficiency rather than like other differential diagnoses of macrocytosis, like hypothyroidism, for example, or a myelodysplastic syndrome. We also suspect it in patients with unexplained psychiatric, neurological symptoms, strict vegan diet, or anything that would interfere with the absorption. If the patient has a history of autoimmune disorders like thyroiditis or vitiligo, the medication history is quite concerning, for example, or presenting with GI symptoms. So B12 deficiency causes a macrocytic megaloblastic anemia, as we can see in the CP solver schema, and a pancytopenia due to marrow failure. Okay, so in order to diagnose a B12 deficiency, we're going to get a CBC, having the MCV with us, RDW, hemolysis markers, reticulocyte count, a peripheral blood smear. We order plasma serum B12 concentration, and we get the metabolites that accumulate, that are the methylmalonic acid and the homocysteine levels. And if we were suspecting pernicious anemia, we would order the intrinsic factor autoantibody. Usually, so for the levels of B12, the serum levels of B12, above 300 is considered normal and deficiency is unlikely. Between 200 to 300, it is considered borderline and deficiency is possible, and you can do other additional testing to confirm that. Below 200 is low and consistent with a deficiency. Um, and in order to confirm the diagnosis of B12 deficiency, we also ordered, as we've mentioned, the methylmalonic acid levels and the homocysteine levels. And when we have to have them both elevated in order to diagnose that patient with a B12 deficiency. However, there are certain conditions that can give you or like alter the levels of MMA or the methylmalonic acid other than B12 deficiency. For example, chronic kidney disease, patients with methylmalonic acidemia, hereditary homocystinemia, and antibiotic treatments. So in such cases, we either order like autoantibodies for pernicious anemia, or we can give them B12 supplements and see if they get if they respond to that treatment. And one of the most important things that I want to mention is some causes of false B12 levels, whether falsely low or falsely high. For example, falsely low, multiple myeloma is a known cause for giving us false B12, low B12 levels. Pregnancy, HIV, diphenylhydantoin, which is an anti-seizure medication. Falsely high or normal levels, occult malignancy, myeloproliferative neoplasms are a well-known cause for giving us markedly elevated B12 levels. Kidney disease, alcoholic liver disease, certain inborn error of metabolism, and about nitrous oxide exposure. It actually gives us, we can get normal B12 levels. However, we have a functional deficiency of B12. So you can see normal levels. However, the B12 that is available is not functioning or not doing its job. And so when we treat our patients and we give them B12 supplements, how long should we wait till we see some improvement in the abnormalities? So for hemolysis markers and reticulocytosis, usually within the first week, like some of them within 1 to 2 days, 3 to 4 days, anemia starts improving within between like week 1 and 2. However, it takes a longer time to normalize, and it may take up to 8 weeks. The hypersegmented neutrophils within around 2 weeks, the leukopenia and thrombocytopenia on an average of 2 to 4 weeks as well. And my last point that I want to mention is that patients with moderate to severe megaloblastic anemia can develop severe hypokalemia in the first 48 hours after being treated with B12 as a result of increased RBC requirements during hematopoiesis. So B12 administration can cause severe hypokalemia, and that's why these patients require close monitoring and supplementation with potassium during this period. And thank you very much. And I hope you guys benefited from my presentation. Uh, yeah, if you have any questions, you can type them in the chat. I'm happy to answer.
Susan, it was amazing. We really wrap everything, and I really love the way you highlight also the management, the points about the diagnosis, and all. It was so interesting to me that how multiple myeloma might have falsely low vitamin B12, while the other multiple neoplasm might have high. So interesting. If anyone have any question, please feel free to put it in the chat. if you look at also the chat, you will see that everybody have the same idea. If not, we are moving to our next presenter, which is Rahul. Rahul also is a great educator. We also always learn a lot from him. Rahul, please feel free to share your screen, introduce yourself, and teach us. Thank you.
Thank you so much, Parisa, for the great opportunity once again. And Sausin, I really loved your, it's like a kind of spaced repetition on vitamin B12 deficiency and all the megaloblastic anemia. Thank you so much. So let me share my screen. Can you guys see my screen? All right. So this is one of the interesting cases where Maddie presented. I think it's one of the bread and butter case of medicine, and Parisa herself and Ravi really laid down the great foundation and made all the great differentials and finally came to the diagnosis. And this was a case presented on Jan 3rd. And coming back, we're starting with the problem statement. So here is a 33-year-old man. He was presenting with an acute to subacute history of pleuritic right-sided chest pain with evidence of tachypnea, tachycardia, and decreased breath sounds on the right side. Coming back to the chief concern, he had some 10-day history of chest pain and aggravated on deep breathing on and exertion. Whenever we see this kind of history where patient is complaining of chest pain, which is increasing on deep breathing, we always think of pleuritic pain, right? And one of the four and rapid and moreover, whenever we are hearing of chest pain, we have to rule out the emergent causes. And moreover, I just want to rule out the emergent causes by following the 4+2+2 mnemonic. That includes cardiac conditions like acute coronary syndrome, MI, aortic dissection, tamponade, and tachystopic cardiomyopathy. But if you look back, is that the patient of 33-year-old guy is very unusual to see acute coronary syndrome dissection in this age group, although it could be possible. And tamponade could only possible in patients with trauma, right? Acute trauma really lead to a lot of pericardial effusion and cardiac tamponade. And coming back to the pulmonary conditions, like emergent pulmonary conditions like pulmonary embolism and pneumothorax would be topmost catastrophic conditions which would result in chest pain and associated shortness of breath. And coming back to the esophageal conditions like esophageal rupture and impaction of foreign body, that could really result in, these are the emergent causes. Once we are comfortable in ruling out the emergent cause of chest pain, now based on the EKG and other labs, now we can tailor our differentials to the non-emergent chest pain. It could be like musculoskeletal involvement, like costochondritis or any kind of herpes zoster and any radiculopathy, any GERD-like manifestations, so on and so forth. But here, the patient is complaining of pleuritic type of chest pain, right? And I always think of 4 Ps whenever the patient is saying pleuritic nature. The 4 Ps include pleural effusion. It could be secondary to pneumonia, so-called. It's also called as parapneumonic effusion. Other possibility would be pericarditis and pneumothorax and pulmonary embolism. So in the four Ps out of 4 Ps, um, pneumothorax would be less unusual because patient with pneumothorax usually present with hyperacute chest pain, and on physical exam you're going to see hyperresonant on percussion and really need a needle decompression with chest tube placement. But however, the presence of the presence of pulmonary embolism, and given he's 33, we really don't know the deep past medical history, and also the presence of pericarditis. I think unless and until the patient has any autoimmune conditions or any malignancy, the pericarditis is also unusual, right? So right now, and even when Parisa was discussing the case, she thought of pulmonary embolism and pleural effusion as one of the two major differentials in the top list. And I really want to emphasize, and Ravi, really, the purpose of putting the sandwich over here is to really make you understand the concept of chest pain sandwich. If you really go back to the embryology, back to our anatomy, the visceral organ like lungs and heart tissue does not have any direct nerve innervation. They are painless. And Rabbit really demonstrated saying that interstitial lung disease, COPD, asthma, and I mean, not asthma, but say COPD or ILD, they're usually painless. Then what is causing the pain in the chest? It's the surrounding the tissue which is encased those organs, like pleural cavity surrounding the lungs, pericardial cavity surrounding the heart. Even in it could be pericardial cavity or and pleural cavity, we have two layers, right? Parietal pleura. And if you zoom in here, this is a ribs and this is a lung tissue, and you can clearly see the parietal pleura over here and visceral pleura. And the name suggests visceral pleura is close to the visceral organs like lung, and parietal pleura is close outside of the lung tissue, close to the muscle. And now even was visceral pleura is painless, it does not have any nerve innervation. It's only the parietal pleura, and of course exterior, organ, the structures like muscle, fascia, and all subcutaneous tissue will carry a lot of pain fibers. But the important takeaway from this presentation, I mean, from this slide, is the parietal pleura is a culprit here that is causing all kind of irritation to the pain, and that is causing making them to come to the ER. Even patients with pericarditis, it's a parietal pericardium getting irritated and coming to the patient. And now the concept of sandwich here is the outside of sandwich, you can think of these ribs and any kind of skeletal muscle, like any muscle spasm could result in acute chest pain, right? And now coming back to the interior organs like heart, and also sometimes mediastinitis, some from esophageal perforation like mediastinitis, any infection carrying from the deep spaces of neck, even reaching into the mediastinum could result in mediastinitis. So the concept of the what is really causing the chest pain will really helps us in ruling out emergent situations, and also keeping the high differential diagnosis in our list, even with chief concern with HPI. So yeah, this is the okay. So this is the same concept. Remember 4 P's: pleural effusion, pneumothorax, pulmonary embolism, and pericarditis. And again, how can rule out pericarditis versus pleural effusion or pleuritic etiology secondary to the pleural cavity? Whenever the patient is complaining of central type of chest pain, because heart is in the middle, right? We can always go through anatomical approach. Now the patient is complaining of central type of chest pain, we can think of pericardial pathology. If the patient is complaining of any lateral side and a unilateral pain, we can think of the pleural pathology, right? In this patient, he's complaining of right-sided chest pain from 8 to 10 days. It's aggravated on deep breathing. Now we could think of the pleural pathology over pericardial pathology at this stage. And now coming back to the HPI, he was fine, he was doing well, and he's feeling feverish and with some right side chest pain and with associated non-productive cough, and he rates his chest pain of 8 out of 10, and of course it's pleuritic nature and minimally responding to Tylenol. And has a recent travel history to Mexico and his occasional use of alcohol, marijuana, and vaping nicotine. And based on the HPI itself, because of associated cough, non-productive cough, and chest pain, we are much more confident in thinking of the lung pathology over any other system. But we did not rule out any pulmonary embolism, right? And coming back to the vitals, he's afebrile, but his respiratory rate of 40 and heart rate of 130 per minute and saturation of 80 at room air, and blood pressure is over 120 over 80 mmHg, and he is in acute respiratory distress with shallow breathing. And he has diminished breath sounds on the right side, but rest of the exam was perfectly fine. Now, if you understand, the patient is coming after 8 to 10 days of the presentation. But if you closely monitor the vitals, he is very sick patient. We really don't know when he's going to collapse. Maybe he also codes. But he's in respiratory distress and using a lot of axillary muscles with presence of shallow breathing. But if you closely pay attention to the respiratory rate, his muscles are working so hard to supply oxygen to the body. And also his heart also working hard. Look at the tachycardia. But imagine the saturation of 80 is not good for the patient, right? We immediately look for A, B, C, D, right? Airway, breathing, circulation, and disability. And we always and Ravi really demonstrated one clinical pearl, which is really outstanding. I really want to emphasize here. If you look at the blood pressure of 128 to 80, it feels like, okay, the patient is fine. But you know what? Generally, we think of if there is a hypotension, the baroreceptors will be activated and really causes tachycardia, right? But there is no presence of hypotension, but still the patient has a tachycardia, which is very, very red flag. We really don't know soon, maybe the patient is going to collapse. Maybe the 120 over 80, maybe some like it's masking the underlying pathology. And if in regards to saturation of 80, the low oxygen saturation, we always start with nasal prongs and then face mask, then NIV and endotracheal intubation based on the clinical status of the patient, and we'll make a quick judgment, right? Imagine, let's say, if the patient, if the same patient, hypothetically speaking, if for example, if the patient is having any hyperacute right side pleuritic type of chest pain, and it could be secondary to the COPD, and one of the differentials was pneumothorax, right? Am I really going to put an NIV for this patient if the patient is deteriorating? Actually not. The saturation of 80 does not mean that if the patient is having a lot of work, increased work of breathing, it does not mean that we have to put NIV. And I really want to go back to the physiology and start thinking of Frank Starling law. The Frank Starling law says that the cardiac output is directly proportional to the preload. The more the preload, the more the cardiac output, and the better the systolic blood pressure. And the preload is regulated by the calf muscle pump, and also more importantly, that generation of negative intrathoracic pressure. Here, I mean, because of the negative intrathoracic pressure, the lot of blood is sucking up into the chest and going on to the right side of the circulation, and that's how the heart will pump all the blood. Now imagine the patient is having pneumothorax hypothetically, and there is a lot of intrathoracic hypertension. On the top of it, if I start an NIV for this patient, imagine how is intrathoracic hypertension is going to be worsened, right? That will further deteriorate the preload, and that will further worsen the cardiac output, and soon the patient will gonna collapse. So the takeaway point from here is, if you're thinking of pneumothorax, don't start on NIV. The better management would be needle decompression with chest replacement. And coming back to the case, and his labs were 25,000 on white count off with 89% on neutrophil, and the rest of the chemistry is fine. So based on the history, we are thinking of respiratory pathology over any other system, right? He got a chest X-ray which showed large right-sided pleural effusion with some laminar atelectasis, and he also got the CAT scan of the neck with contrast. So the rationale behind getting the CAT scan of the neck with the Doppler with contrast is, with this presentation of subacute history, we always have to think of anaerobic bacteria, like kind of Lemry syndrome, where it really invades the internal jugular vein, and that will carry all the septic focal of infection down to the lung tissue, and you're going to see a septic embolic manifestation. But fortunately, our patient does not have any evidence of thrombophlebitis and no fluid collection. And based on his right pleural effusion, he also got the thoracosynthesis, which really revealed cloudy fluid, the pH of less than 6.8, very low glucose, and protein is 5.2, and LDH is very skyrocket, it's 3000, and white count of 105 with presence of gram-positive cocci and bacilli. Now, if you apply our step one principle here, the presence of taking the lights creates classical of X-ray to pathology, right? And as a part of further management, he got the chest tube that really revealed large amount of purulent fluid, and he got the chest tube placed. And the diagnosis was made, because if you're seeing the purulent fluid and we diagnose the patient as an empyema, now you may wonder where this empyema is coming from. Is it because of the localized pneumonia like parapneumonic effusion causing the empyema, or is any secondary process, any kind of embolization like pattern? Unfortunately, this patient had poor dentition, and because of the odontogenic fusobacterial nucleatum infection, he got the empyema because of aspiration, I guess. Now, I really want to focus our discussion on empyema. What is empyema? The name suggests, if you closely understand the name, the pyma means pus, right? The presence of pus in the pleural cavity. So this is one of the good pathophysiology I got from one of the review articles. And now I really want to emphasize here on the pathophysiology of empyema. Is empyema is going to start on first day itself? Not really. It takes time. The body takes time to form a exudative fluid to the lot of white cell to the bacteria, and then there's a formation of pus. So that really includes three steps of pathophysiology. One is exudative phase. Is usually, because let's say if we have any kind of tissue trauma or any kind of skin trauma, usually see kind of swelling and all the neutrophil. If you go back to the inflammation principles, there will be a lot of vascular permeability, and neutrophil will come there and invite all the formation of platelet plug formation to prevent bleeding, right? Imagine the same thing is happening on the pleural cavity. There is initial inflammation, and there is the presence of neutrophilic chemotaxis and vascular permeability, and all these things is really causing an exudative pattern of pleural effusion. Now, hypothetically, let's say this patient comes to the clinic or to the hospital at this stage. and let's say we'll get the chest X-ray or CAT scan of the chest. And sometimes even in our inpatient pneumonia patients, we see some evidence of small right or left side pleural effusion, but we don't drain it, right? We are going to label these patients as simple pleural effusion secondary to the pneumonia or parapneumonic simple effusion. And we really don't drain it because there is no need to drain it. And if you look at the biochemistry, hypothetically, if we drain it, if you study the plurals, if you do the plural studies, the pH will be greater than 7.20, glucose will be greater than 60 because there is no such great bacteria which is consuming a lot of glucose, and LDH will be less than 1,000, and there is presence of no microorganisms present. Now imagine the patient at this stage is not coming to the hospital, not coming to the clinic, and is sitting at home self-managing some with Tylenol. And now the oxidative phase is going into the next phase called fibropurulent phase. What's going to happen in this patient? In this phase, it's not only neutrophil. Now all the inflammatory molecules along with the bacteria will try to squeeze out of the lung tissue and goes into the pleural cavity. It's not only end there, it's going to activate all the coagulation cascade, and there will be deposition of all the fibrin that is really causing a lot of issue to the patient. Now at this stage, we are going to label this patient as complicated pleural parapneumonic effusion. And as you see, because there's a presence of bacteria and all the with presence of myeloperoxidase coming from the neutrophils and all the other enzymes and other cellular debris, this really makes fluid as very cloudy. And because of the presence of fibrin molecules, it's going to make a lot of flocculations and septa, right? And if you do the biochemistry, if you do the pleural fluid analysis at this stage, the pH will be less than 7.20 and glucose will be less than 60 because all the bacteria is going to eat up the glucose, right, for its necessity, for its growth, and LDH will be skyrockets greater than 1,000. Now imagine even the patient is not coming to this stage, and if he's not receiving the appropriate treatment or in wrong antibiotic, now he's going to go into this next phase called organizing phase, where there will be all the accumulation and will bacteria inflammatory cells remains there, and there will be now there will be activation of fibroblasts will come there, and there will be fibrosis. Now you could imagine all these acute inflammation to the chronic inflammation phase going on here, and the fibroblast attraction, and there'll be formation of all the fibrosis over the pleural surfaces. Now at this stage, we are going to label this patient as empyema or presence of pus, and you're going to see the same biochemistry. Now the simple difference between complicated parapneumonic effusion versus empyema is, if you're seeing pus in the pleural cavity on your chest tube, label this patient as empyema. Now, if you think back, looking at the HPI chief concern, and all these things are really fitting under the category of empyema, right? And now this is one of the other schema I got from the CP Solvers website, again showing the same thing. In usually uncomplicated, it's usually free floating, oxidative pattern. It does not require any management, no presence of bacteria, usually requires an empirical antibiotics, and it's going to resolve on its own. Now it goes to the complicated and empyema, going to say loculations, which really requires antibiotics with presence of chest tube and chest tube placement. And the most common organisms include, as you know, the streptococcal pneumonia and oral anaerobes, like in this patient, like Fusobacterium and Staph aureus. And I really want to emphasize on one point here: Staph aureus, like particularly MRSA, causes necrotizing pneumonia, which is, I think, it's the most common organism which really causes that. And I got this image, and if you look at this, the lung ultrasound here, there's a lot of fluid over here, and you can see all the loculations like hexagonal, like benzene shaped ring, right, and proper septa and everything. Now imagine if I'm trying to put the chest tube, if I can't break the septa, am I really going to yield the pleural fluid? Not really. Now I have to intertwine something to the chest tube to break down all the loculations and get rid of the fluid, right? It does not end with chest tube. We need to do some other additional molecule to get rid of this septal two septations. And this other the other algorithm I got from American College of Chest Physicians, where again the same principle, where they're going to categorize based on anatomy, it's free fluid or small to moderate or large, and what presence of bacteria or not, and with presence of both bacterial culture and gram stain and pleural fluid chemistry. And they're going to categorize based on based on the status, it's very low or low risk, moderate risk, and high risk. The patient with the moderate and high risk really require a great antibiotic therapy with chest tube placement. And I just want to share some of the management pearls for empyema and pleural effusion per se. And as literature says, 10% of the patients with parapneumonic effusions really requires drainage of the fluid. And if you're seeing the patient as an inpatient, and if you're really comfortable in doing the thoracocentesis based on the history on the imaging, try to do it. If it delay by days, now all these phases, now exudative phase is going to go into fibropluent phase. Fibropluent is going to into organizing phase, and we are giving the time for the bacteria to become loculations, and we really need some great intervention if we delay it. And as I mentioned, the best management would be chest tube placement, and with addition of some other molecule. I'm gonna share what that molecule is. The chest tube should be placed in a dependent portion of the pleural effusion, and more importantly is the correct position of chest tube placement is much more important than the size, because larger size means we need to do the larger incision, right? And after putting the chest tube, we really need to monitor the patient. Is the patient respiratory rate getting better? Is the patient heart rate getting better? What is the blood pressure? What is the saturation at room air doing? And is he walking okay? Is he eating okay? And moreover, maybe getting a repeat ultrasound the next day and see. And also, and I really want to. I saw some of the case of empyema in the US and India. If you clearly look at the chest tube drainage container, and all, if you, and the bottom of the container, you're going to see dark thickened fluid, and that is really cellular debris and all the content, all the proteins. And the top of it, after 2 to 3 days of starting management, you're going to see a lot of serous fluid, which is dancing on the top. And by any ways, if the patient is not getting better, is pleural, the fluid is not getting, you're not yielding on an anticipated pleural fluid, it means something is going wrong. Maybe we are giving the wrong antibiotic. Maybe we did not place a chest tube correctly. In that situation, we really want to look back and look at the history and see whether we are doing in the right thing or not, or it's okay, it's worth it to get an ultrasound or POCUS or CAT scan to really see what's going on. Maybe the loculations are getting bigger and bigger, in which the patient is not responding to the chest tube. In that situation, we really want to intervene. We really want to bring cardiothoracic surgery on board and pulmonology on board to see what could be the best next step. And as I mentioned, the other molecule is, along with chest tube, it's TPA, tissue plasminogen activator, and it's 10 mg. Usually in the US, usually if they're putting in a chest tube, usually the IR does all the procedure, the IR or surgery. And they try to do is, what they try to do is they push the 10 mg of TPA into the chest tube. That will, the TPA, right? We usually give it for stroke patient, but the required the dose was completely different for stroke. And for the empyema, the recommended dose is 10 mg, where we really push into the chest tube. That will really cleave all the septations which you saw on the ultrasound image, and maximum we can repeat up to 3 doses. And still, if you are not getting the pleural fluid, it means we need to intervene something by doing an interventional procedure like any scope, thoracoscopy, or doing some surgery. As I mentioned, if you're not yielding a gray anticipated pleural fluid, it's a time we need to do the scope. We need to break all the lysis, break all the additions to get back to all the fluid. Still, if the patient is not getting better, if you remember in the fibroblastic phase and the formation of all the fibrosis, right? Now we have to remove all the fibrous tissue from the parietal pleura and visceral pleura, and we have to evacuate all the pus, and that is called the decortication. And moreover, literature says decortication should not just be performed to remove the thickened pleura, because the thickening usually resolves spontaneously over several months. But if the patient pulmonary status function is getting very poor, even after 6 months, it's time to consider decortication, that because that significantly improves the activities of daily living of the patient and also pulmonary function test. So these are my references from American Thoracic Journal, Thoracic Society, and CP Solver Schema. And thank you so much, Parisa, and thank you so much for the entire CPS family and all the audience who are patiently listening all the presentations. Thank you so much. And I'm happy to take any questions.
Thank you, Rahul. It was amazing starting the whole journey from the patient. It is a thing happening in the internal medicine, starting from chest pain sandwich, talking about pathophysiology of the empyema, and you also beautifully talking about management. I personally learn a lot, and if you look at the chat, see how people really enjoyed the presentation. It was a master presentation. We learned a lot. Thank you so much. If anyone has any question, please feel free to put it in the chat. If not, we are moving to Patricia. Patricia is a great doctor. She's taking care of the patient in the real life, and now she's going to teach us about amyloidosis. Patricia, please introduce yourself and feel free to share the screen.
Hey everyone, thank you, Parisa, for this warm welcoming. So, give me a minute to share my screen. Okay, can everyone see my screen? Okay, so is everyone able to hear me? Yes? No?
Yes, we do.
Okay, thank you. So here, I'm Patricia. I am an IMG from Cameroon, and today I will do a teaching point recap of a case we had on January 3rd, which was presented by Lyra and discussed by Rabi and Madi. So our case started with a 56-year-old woman which presented with shortness of breath and fatigue for 2 years. We started the discussion with dyspnea, and in CPS we have a nice schema about dyspnea. We start to think about different etiology from the lung, like COPD, asthma, cardiac etiology, CHF, aortic stenosis, or other etiology like anemia or anxiety. After this discussion of dyspnea, we had more information about our patient. So it was the patient's developed symptom from 2 years is a long time, but she actually came to the hospital because of a worsening shortness of breath, non-positive cough and edema of the lower extremities. She did not have any orthopnea, no palpitation, no recent fever or weight loss. On past medical history, she did not have any hypertension, no diabetes or cardiovascular disease. Physical exam was relevant for a blood pressure at 100/70 and a heart rate at 115. She had GVD, bilateral diminished breath sound, and lower leg beating edema. Her lab and imaging was relevant for a hyponatremia at 125. A echocardiogram showed an ejection fraction at 45% with left ventricular hypertrophy and left ventricular outflow tract obstruction. She also had right-sided pleural effusion, no wall or normality were noted, and her condition improved on diuretics. So we talk a bit about left ventricular hypertrophy. We ask ourselves like, what can be the cause? It's usually load dependent or load independent. In the load dependent causes, we have hypertension or aortic stenosis, and load independent cause, we have hypertrophic cardiomyopathy or infiltrative disease. So to summarize our case, we had like our 50-year-old woman, we had symptom of heart failure. She has sinus tachycardia for 2 years, and she also have left ventricular wall thickness, no sign of high output heart failure, or no sign of cardiogenic shock. The discussion goes more and more toward restrictive cardiomyopathy. So what is restrictive cardiomyopathy? Is a myocardial disorder that usually results from increased myocardial stiffness that lead to impaired ventricular filling. We have a lot of causes, and I was able to gather 3 main causes. Infiltrative causes like amyloidosis, sarcoidosis, storage disease like Fabry's disease, Gaucher disease, hereditary hemochromatosis, or non-infiltrative causes like diabetes, cardiomyopathy, sarcomeric protein disorder. And the more we talk in the discussion, the more we talk about amyloidosis, which is the main title of our discussion today, restrictive cardiomyopathy / amyloidosis. So cardiac amyloidosis. So what is amyloidosis? It's a syndrome characterized by the extracellular deposition of misfolded protein as amyloid, leading to organ functional loss. Amyloid deposition in the heart lead to cardiomyocyte separation, cellular toxicity, apoptosis, and tissue stiffness. It's important to know that we have like several kind of amyloid, like more than 75 subtype of amyloid, and it's actually like 35 subtype that can be like harmful for the body. But the most common type of amyloid that can affect the heart are actually ATTR and AL amyloidosis. So to talk more about them, the ATTR amyloidosis, like this is a table that, as you can see, gives you the difference and some
Patricia,
interesting.
sorry to interrupt. We are not able to see your screen anymore.
Oh, can you see?
Oh, okay. It is just me then. Everybody else can see. Okay, sorry. Go ahead.
Okay, but thank you for letting me know. So I hope everyone is able to see the table. Marisa, can you?
Yes, it's
No?
fixed. Sorry.
Okay. So the table is, as I was saying, a great is some facts and some differences between ATTR and AL amyloidosis. ATTR amyloidosis or senile cardiac amyloidosis come from an abnormal production of TTR, which is a transport thyroxine and retinol protein that is formed in the liver. It's important to have like in the back of our mind when we have like a older man, like more than 70 years old, who came with heart failure with preserved ejection fraction and left ventricular thickness. It's important to have like amyloidosis on the back of our mind, or a patient like with the same on that same age range who came with severe aortic stenosis. It's also important to have like amyloidosis, like especially ATTR amyloidosis in the back of our mind when we think about when a patient came with a bilateral carpal tunnel syndrome. Extra manifestation of ATTR amyloidosis are pretty rare, and it has a better prognosis and response to treatment compared to AL amyloidosis, which is an abnormal production of clonal immunoglobulin protein from the bone marrow. It's actually like a different modification compared to multiple myeloma. Like later on, we'll see that they sometimes can be linked together. So AL amyloidosis is it doesn't have like a specific population range. We just know that it's usually patients who are more than 40 years old, and it has a lot of extracardiac manifestation, like can be associated with nephrotic syndrome because the amyloid can deposit in the kidney, it can deposit in the tongue and give you like macroglossia. It can also deposit under the eyes, giving the patient the periorbital edema or peripheral neuropathy. Unfortunately, it has a poor prognosis, and as I was saying, it can be associated with multiple myeloma. Okay, so clinical presentation, how restrictive cardiomyopathy / amyloidosis presented. It can present with heart failure symptoms like with our patient, poor exercise tolerance, syncope, advanced valvular heart disease, extracardiac manifestation like proteinuria, elevated creatinine, hepatomegaly, and imaging and labs. We have some relevant information with the EKG. We can show low voltage QRS complex, which was the case in our case. Unfortunately, I did not put the EKG in our presentation, but it was confirmed like in our case. So low voltages in QRS complex, pseudo infarct pattern with Q wave. The echocardiogram can show concentric thickening of the left ventricular free wall, left outflow obstruction, and high filling pressure. The MRI usually show late gadolinium enhancement is a hallmark for amyloidosis. Cardiac biomarker, we have elevated BNP and troponin. And usually the gold standard is the endomyocardial biopsy. After we take the biopsy, we do the Congo red stain. If it's positive, it has a greater chance to it has a greater chance toward the diagnostic of cardiac amyloidosis. But it's important for us to know the subtype. Is it ATTR? Is it AL? So we do a mass spectrometry, which is more specific to know which type of amyloidosis it is. So the treatment for cardiac amyloidosis depend on the subtype, as I was saying. In AL amyloidosis, we treat it as multiple myeloma. So the goal is to remove the paraprotein from the blood and stabilize the bone marrow. We can do chemotherapy or stem cell transplant. TTR amyloidosis has, compared to AL, if you remember the table, it has a better prognostic, and we can actually use medication like TTR stabilizer, which show great outcome for the disease, and it responds well to heart transplant and liver transplant. Liver transplant, since the TTR protein are usually formed in the liver, and it also has a great response to gene silencer. And a good thing to know is that if the patient with cardiac amyloidosis present with heart failure, it usually had good response to diuretics, mineralocorticoid, but it's important to avoid beta blocker because those patients usually have high filling pressure, and beta blocker not only high filling pressure and tachycardia, and beta blocker not only reduce the heart rate, but it can also reduce the preload, which usually cause hypotension. So, and like a patient who usually we come with heart failure, you give them beta blocker and they do not respond well, is a high sign that the patient might have amyloidosis. So yes, just pay attention to that. You will never know. Yeah, so to conclude and to go back to our patient, she, after the result from her echocardiogram, her heart failure symptom, we did more exam. We did an MRI, which show hypertrophy of both ventricle with diffuse late gadolinium enhancement and thrombotic masses present in the atria and IVC. She then did, like, that is telltale sign that she has a high chance to have cardiac amyloidosis. So then we do a cardiac scintigraphy to know which kind of amyloidosis it is. Is it AL or ATTR? The scintigraphy was negative for ATTR amyloidosis. So we contact, and in our case, they contacted hematology. We did a SPEP with immunofixation, which show IgG paraprotein, free light chain lambda was elevated. So it confirmed the presence of AL amyloidosis. Then we do a full body CT scan, which show a sclerotic lesion in the skull, and the bone marrow biopsy show is extra plasma cell of more than 50%. Unfortunately, it was a very bad diagnostic. Like, we had multiple myeloma with AL amyloidosis. Usually it does not have a good prognostic. So our patient in that case were more like palliative care. So thank you. Our references was an article on restrictive cardiomyopathy and cardiac amyloidosis, and also a great podcast from CardioNerd episode 252. I recommend everyone to listen to it. I really enjoy it. Thank you so much, everyone, for your attention and yeah, thank you.
Patricia, it was amazing. Thank you so much for beautifully explaining amyloidosis, going through the different type, talking about the EKG. Oh, I'm too bad. Talking about the EKG, and I think I really love the way you talk about the management and also how it was applied in terms of this specific patient. Talking about how EKG, it was the crux of that specific discussion, and you walk us through every single step of that discussion. We really enjoyed a lot, and if you look at the chat, you could also see how people really enjoyed it a lot. Thank you so much. If anyone have any question, please feel free to put it in the chat. And also accept my apology for interrupting you in middle. I think if not, that's it for today. Thank you everyone for joining us, and special thanks to Susan, Rahul, and Patricia for teaching us. It was a rich session. We learned a lot, and that's it. See you tomorrow for Stefan and Zaven discussion. Bye, everyone.